So the worst in terms of this particular outbreak possibly is over. I think what we're seeing is a decline in relation to this wave of the outbreak, but that doesn't mean that we won't necessarily have a second or third wave. I think the reality of this virus is that there's still a lot of knowledge that needs to be gathered in terms of how this virus behaves, how people develop an immune response to it, and whether that immune response which they develop, which is induced following the viral infection, actually results in long-lasting protection against COVID-19. Now, as you mentioned, there has been a decline in terms of the number of cases in South Africa. That decline is probably for two reasons. On the one hand, I think there is an actual reduction in terms of the amount of transmission that's taking place, and that is evident from our hospitals, where the rate of hospitalization is actually decreasing, especially in the Western Cape, in Gauteng, in the Eastern Cape, and to some extent in KwaZulu-Natal as well as some of the other provinces. We are seeing a decline in terms of the number of people that are being admitted on a day-to-day basis with COVID-19. But on the other hand, we're probably overestimating the reduction, because what's also happened over the past 2 to 3 weeks is that the number of people that have come forward for testing has actually declined. So at the peak of the testing, we were testing roughly about 45 to 50,000 individuals per day. And that has now dropped to roughly about 15 to 20,000. So the decline in terms of the amount of testing that you're doing would obviously contribute in terms of a reduction with regard to the number of people that are diagnosed as having COVID-19. But in short, I think we are probably over the worst in terms of this particular wave of the outbreak, but that doesn't mean we're completely out of the woods, because the virus is still very much circulating. People are still being admitted with COVID-19, and people, unfortunately, are still dying from COVID-19. So this doesn't mean that we need to become any less vigilant in terms of adopting the measures that have been recommended, including avoiding overcrowded spaces, including ensuring that you're wearing face masks in public, maintaining physical distancing, and when in closed spaces, ensuring that there's good ventilation. So I think it probably differs across the country. What we've seen happen in South Africa, which is not dissimilar to many other countries, is that a large percentage of the infections that do take place actually occurs in a very small part of the population. So roughly about 10 to 20% of the population would be responsible for up to about 80% of all of the infections that take place, or 10 to 20% of communities would be responsible for up to about 80% of all infections that take place. And those communities that are most affected and that are at highest risk of being infected, especially in terms of the first wave of the outbreak, are people that live in communities that are very densely populated. So as an example, your urban areas, your inner city, places such as Alexandra, Soweto, Ayesha, those are the areas where there's a high density in terms of population, and unfortunately the conditions under which many people live in those sort of settings doesn't really lend itself to being able to control the spread of the virus. So we find a lot of infection taking place in those particular settings. Whereas if you go into your middle class communities where people have the luxury of having multiple rooms in a house, are able to adhere to physical distancing, there is infection taking place there as well. No community is going to be spared from being infected. But the amount of infections, or the percentage of the population that are being infected in those areas, in the more affluent areas, probably would be lower. So something that needs to be done in South Africa, and that will probably be rolled out over the space of the next month or so in the different provinces, is what we call a sero survey. So a sero survey is testing whether people have been infected, at least whether they've been infected up to 21 days ago. And that is taking either some blood from an individual. The blood can be taken by taking a usual blood draw, or just taking a finger prick and testing for antibody against the virus. So that won't tell us whether someone is infectious at the moment, but it assists us in terms of understanding what percentage of the population have been infected in different communities. And it's important to understand this at a community. And the reason why it's important to understand that at a community level is exactly the point that you raised in terms of herd immunity. So what herd immunity is when a substantial percentage of the population has actually developed immunity against the virus. what happens is that those individuals become less susceptible to being infected if the virus is still circulating in those communities. So in doing so, there's almost an interruption in terms of the chain of transmission of the virus. So people can still get exposed to the virus, and even if they do become reinfected, it's unlikely they're going to be infectious for a very long period. They're not going to shed the virus for a long period, and they're not going to transmit the virus onwards to other people in close proximity to them. So for this particular virus, our estimate is roughly about 40 to 60% of people in different communities would probably need to have been infected before we have this break in terms of the chain of transmission of the virus. Whether that has already happened in South Africa, my estimate is that certainly in some communities, especially very highly densely populated areas, we might well see that up to about 40% of people were actually infected with a single wave of the outbreak. Whereas in other communities, the more affluent communities, we are probably going to find that that percentage is much lower. So to some extent, this whole concept of herd immunity or community immunity is likely to be based on what has occurred in different sub-districts, and that will influence what we can expect to experience moving forward. So we're now conducting 2 vaccine studies, and the second one that we just started about a week ago, so it's still at an early stage. With the first one, we've currently enrolled roughly about 3/4 of the participants, and they all need to get 2 doses of vaccine, and that is still taking place. So right now, the enrollment into the studies is going reasonably well. We've had a lot of volunteers that have come forward to participate, and we're still inviting others to come forward. And I think it's especially important for us to understand how this vaccine works in South Africa, that we have a good demographic representation in terms of the people that volunteer to come onto the studies, because at the end of the day, we are wanting to know how this vaccine works across the South African spectrum of population rather than in any specific demographic group. And fortunately for the first study, certainly we've had a good representation from different ethnic, race, religious groups across South Africa, which really assists us in terms of understanding how the vaccine would work in the South African context. In terms of when we're going to get an answer as to whether the vaccine actually protects against COVID-19 or not, it's difficult to tell. Initially, we thought that we might be able to get an answer from the first vaccine study as early as November or December, but that was at a time when we were finding a lot of circulation of the virus in the country. Now that the amount of virus that's been circulating in the country is decreasing, it might take us longer to be able to answer that particular question. So the way the studies are conducted is that when participants come forward, they are assigned to one of 2 groups. One group will receive 2 doses of the vaccine, and the other group would receive 2 doses of the placebo. And neither the participants nor the investigators would know who has been allocated to which group. And then we follow up all of those individuals. And unfortunately, because the virus is circulating in the country, some people are going to develop COVID-19. Once we've had about 42 participants that have developed COVID-19, at least 2 weeks after they've received the second dose of vaccine, at that stage, we can do an analysis to see whether there's any difference in terms of the attack rate between these groups. And that allows us to make a conclusion as to whether the vaccine actually protects against COVID-19 or not. So with the current projections, it's really difficult to estimate, but right now I don't think we'll get an answer by the end of 2020. It might take us a few more months into 2021 before we know whether the vaccine protects against COVID-19, at least in South Africa. Right, so currently there's about 40 vaccines that are in human studies across the world. And in South Africa, as we mentioned, there's 2 studies that are currently underway. These vaccines are different in terms of they use a different sort of technology, a different platform to construct the vaccine. So the first vaccine study is a vaccine that was developed at the University of Oxford, and that is what is known as a simian adenovirus vector vaccine, which basically means it takes adenovirus that is not usually found in the human population, but doesn't cause illness in the human population either. It genetically modifies it in such a way that it is no longer able to replicate, and then inserted into that is the genetic material that codes for a protein which is of special interest to us, known as a spike protein. And that's a very important protein that the SARS coronavirus 2 uses to attach to the human cell. So once that is inserted into that virus and injected into a person, the person's body, the human cells, actually uses that information that's being delivered by the virus to start producing that protein known as a spike protein. And that protein is then presented to the immune system, and the immune system will develop a response to that particular protein. And that response includes what we call antibodies, which are important for protecting against developing severe COVID-19. And there's also other parts of the immune system that's stimulated. So that is the vaccine that was developed at the University of Oxford. It is known as a virus vector vaccine. The other vaccine that we're evaluating is a vaccine that's being developed by Novavax, which is a biotechnology company in the United States. And that uses a somewhat more traditional approach in terms of vaccine design, and that is it uses the protein itself. So rather than getting the body's cells to produce this protein by delivering the genetic material, it now actually uses the protein itself, which is coupled to another molecule, to enhance the body's immune response to that. And that substance is then injected into an individual. And again, the body's immune system recognizes it as being something that's foreign, and this results in the production of antibody as well as what we call T-cell immunity. So these are two different proteins for two different vaccines. For both of these vaccines, individuals need to get at least 2 doses of the vaccine that are spaced about 3 to 4 weeks apart before they get the type of immune responses that we think would be required to protect against COVID-19. And then there's a number of other technologies that are also being used. There's 2 other types of technologies that are also being used for vaccine design, but those vaccines are not under evaluation in South Africa currently. Correct. So the first thing is for a vaccine to be able to protect against severe COVID-19. And that is what we really develop vaccines for, to protect against severe disease and to prevent people from dying. So that's the most important thing. Now, in addition to that, it would be a huge gain for us. It would be a huge advantage and benefit if the vaccine, in addition to protecting against severe disease, is also able to protect against infection with the virus. So when you develop severe disease, much of that illness is occurring in the lungs, which occurs in probably less than 5% of people that become infected with the virus. And people that have comorbidities end up having more severe disease in the lungs. But 95% of people that get infected with this virus will either be completely asymptomatic or they'll have a mild infection, which is limited to the upper airways. But the reason why those individuals are important to us is because they are the ones that are usually healthy, walking around and spreading the virus to other people. So if we can get a vaccine that protects both against severe disease as well as prevent people or protects people from getting infected in the upper airways, or at least reduces the amount of virus they end up getting after they're infected in the upper airways, that type of a vaccine would be the ideal vaccine. So for a vaccine to be able to do that, it needs to protect both against COVID-19 as well as infection in the upper airways. And there's very few vaccines that are capable of doing that. So we're trying to develop vaccines that are able to do it. And certainly from the initial experiments that were done in the non-human primates, as an example with the spike protein vaccine that I referred to, after the macaques were given 2 doses of the vaccine and they were given a challenge of the virus into the nose, which is not what we do in humans. This is an artificial challenge of the virus into the nose or into the lung. They found that 2 doses of vaccine in the macaques actually protects them against infection, both in upper airways as well as in the lungs. So that is a very positive signal, and it's promising that we might be able to achieve that in humans as well. But the only way that we'll know whether we're able to achieve it is by doing these sort of vaccine studies. Yeah, so I think in terms of the Russian vaccine, we just need to be careful in that even though there's 20 countries that might be ordering the vaccine in advance, the reality is that we don't have any information to say whether that vaccine is actually safe or whether it actually protects against COVID-19. So those studies need to be done. If all of the other companies use the same benchmark as Russia to license a vaccine, then right now we won't have two vaccines that are licensed, one in Russia and one in China, but we'll probably have almost 20 vaccines that are already licensed. But that's not the way you go about licensing a vaccine. You need to first establish the safety of the vaccine, and then you need to do the studies, the experiments to show that the vaccine actually protects against COVID-19. And it's only after that that you should actually be licensing a vaccine. So unfortunately, what the Russians have done is premature, and it doesn't mean that they've got a vaccine that protects against COVID-19. And the only time will tell after they've done the studies on that vaccine as to whether it actually protects against COVID-19. So in terms of Africa's role when it comes to the COVID-19 vaccine landscape, I think what we're doing in South Africa is very much leading the field on the African continent and being pretty much competitive globally in terms of the type of work that's being done around the clinical development of vaccines. Unfortunately, what we don't have in Africa, and we haven't been doing this for decades now, is we don't have manufacturing facility. And our scientists there hasn't been enough investment in terms of science on the continent for our scientists to be able to develop their own COVID-19 vaccines. And then in the private sector, there simply aren't those manufacturing facilities for us to be able to manufacture vaccine on the African continent. So that makes it all the more important for us to be involved at some level in terms of the clinical development of the vaccine. Because if we're not involved in terms of the evaluation of the vaccine, we might well find ourselves in the situation that when the vaccine becomes available, we simply don't know whether this vaccine actually works in our own context or not. In addition to which, if we're not seen to be spearheading or being right in the front of the queue with regard to the clinical evaluation of this vaccine, it becomes much more difficult to make a case as to why the vaccines should be provided to South Africa, to Africans at an early stage of its development. We need to understand that for COVID-19 vaccines to be of public health value, we don't just require a single vaccine. We're going to require at least 4 to 5 vaccines that are licensed in the space of the next 6 to 12 months, because there's no company in the world that's going to be producing billions of doses of vaccine for 1 or 2 years and put all of the investment in that. And after that, that becomes almost a white elephant. So we need multiple companies to be successful. We need to be involved in the clinical development of these vaccines, so that we can generate the evidence to show how these vaccines work, which of the vaccines are best suited for our own setting, and then make a case eventually as to why these vaccines should be made accessible and available to African countries at an early stage after its production. Correct. So unfortunately, that is already occurring. There's many high-income countries, including the United States, United Kingdom, Germany, and a few others, that have already put up money up front before we even know whether the vaccines are working or not. They've already purchased vaccines in advance. So they've told companies, we're giving you $1.3 or $1.6 billion, and this is the amount of vaccines that we want you to provide to us once you start developing the vaccine. So in a sense, they probably already purchased the first few 100 million doses of vaccine that will become available in the first 6 months of next year. So it's going to be a struggle for low middle income countries, including South Africa, to gain access to these vaccines. But there is an initiative known as COVAX, which is being led by Gavi, which is a Global Alliance for Vaccines and Immunization Initiative, to try to develop a framework that will assist low income and middle income countries to be able to procure vaccine at least for a percentage of its population. So we're not talking of vaccinating 60 million South Africans. We're talking of possibly vaccinating perhaps 2 million South Africans in the space of the next 12 months. So there's going to be, hopefully there will be some vaccine that becomes available at a relatively early stage after the vaccines are shown to be effective. South Africa will probably need to purchase those vaccines, and then we'll need to do some sort of prioritization in South Africa as to who would benefit the most from being vaccinated at an early stage when the supply of vaccine is fairly limited. Yeah, so it's difficult to speak on behalf of government, but I think the history of vaccines in South Africa is that vaccines have always been, life-saving vaccines have always been available through the public sector, as well as can be purchased through the private sector. But the reality for this vaccine is, like I mentioned, we're probably going to have a very limited supply of vaccine that's going to be available to us. So we're not going to be seeing too much vaccine in the private sector, if any vaccine in the private sector. All of the vaccine that probably would be made available to South Africans in the first few months after the vaccines are developed, or sometime during the course of next year, will probably be purchased or offered directly to government. And then government will need to work out what is a prioritization in terms of who should receive vaccine. And that priority groups are also being debated by the World Health Organization, and it will likely include healthcare workers at the front line, it's other essential public healthcare service, other people that are essential workers, as well as people with morbidities or individuals at a high risk of developing severe disease. So those will be the limited number of individuals that will possibly receive vaccine sometime during the course of next year. But in all likelihood, it is vaccine that will be purchased by government on behalf of the country to be utilized in those priority groups. Yeah, so I mean, these vaccines are using very different sort of technologies. And as an example, the vaccine that's currently available in the two vaccines that are being used in South Africa, they don't contain any sort of what you term as RAM products in the vaccine itself. But like I said, there's 40 different vaccines that are currently under development. And I think at the end of the day, we also need to just be careful in terms of how we position that sort of a narrative, because at the end of the day, we're talking of a life-threatening illness. And we can't, unless we got our own companies and Muslim governments that are funding studies and developing their own vaccines, the reality is that that is a secondary issue when dealing with a crisis that we're actually dealing with right now. So people are going to be free to accept or not accept the vaccine, but at the end of the day, what we really require right now are vaccines that are able to break the back of this pandemic, which is not just affecting the health of people, which is destroying livelihoods, which is destroying countries. Well, even if a vaccine becomes available to South Africa, that's just a starting point, because the reality in South Africa is that we don't have too much by way of vaccination of adult populations. We've got a reasonably good program when it comes to vaccination of children, but less so when it comes to vaccination of adults. As an example, with influenza vaccine, which is usually targeted at adults, in South Africa, we roughly distribute about 1 million doses of influenza vaccine each year. And even then, it's sort of it's all over the show in terms of how you get access to the vaccine and who gets vaccinated. So the entire structure in the delivery system to ensure that we're able to immunize people timeously and get it to the people that really require it are challenges that we still need to think through. And that is the type of work that needs to be started now, so that when a vaccine becomes available, hopefully in the second quarter of next year, we don't spend another few months trying to understand how to go about vaccinating individuals that are in greatest need of the vaccine. Yeah, I mean, that's going to be an individual choice at the end of the day. And like I said, at the end of the day, it's not that we're going to have 60 million doses of vaccine and that everyone is going to be forced to actually receive the vaccine. The reality, unfortunately, is that we would be highly lucky, very lucky, if we were even to get 2 million doses of vaccine. So there's not going to be any shortage of individuals that are wanting to be vaccinated. So if people are not wanting to be vaccinated, that would be their right. But yeah, I don't think that's too much of a concern right now. Unlike measles vaccine, which is a very different story, where you need to get about 95% of the population to be vaccinated to develop this herd immunity. When it comes to the Covid19, you probably need to get about 60 to 70% of the population to be vaccinated to reach that same sort of herd immunity threshold. So I'm not too concerned about the few individuals not wanting to be vaccinated for whatever reason. But at the end of the day, if we get enough vaccine, it's in the public interest for people to be vaccinated. It's not just about their own protection, but it's also about them playing a role in terms of the transmission of the virus to other individuals that they come into contact with. And had they been vaccinated, they wouldn't have done that. Yeah, so I think what we're seeing being experienced in the Northern Hemisphere countries is that a majority of countries are experiencing second wave. And whether you want to call it the second wave or whether you want to call it the rebound and of the current outbreak, those are probably semantics. But the reality is that after many countries, the rate of infection had declined. As the societies opened up, we saw more transmission taking place, and subsequently we've seen an increase on the day-to-day number of cases that are being reported. I don't think South Africa is going to be any less, it's going to be unique in that we probably will also experience 2 or 3 further outbreaks. But the big question is, when are those additional outbreaks going to occur, and what is going to be the magnitude of those additional outbreaks? My feeling is that, firstly, it's difficult to predict when those additional outbreaks are going to occur. It largely depends on the behavior of citizens. If people start ignoring the recommendations not to gather in mass groups, if they start not using face masks, if they start not maintaining physical distancing, then we're going to get a second outbreak or a rebound sooner than we would like. It might happen in the next 1 or 2 months. But if people continue adhering to those non-pharmaceutical interventions that we recommend, then it will take probably longer for that rebound, for that second wave to occur. So that's the first part. It's difficult to predict exactly when it's going to occur. But the second big issue, like I mentioned, is whether the next waves are going to be any less severe or more severe than the current wave. And my feeling is that there's been a large percentage of people that have been infected this time around. And in all likelihood, even if we are to experience a second wave, the magnitude of the second wave probably will be less than what we experienced this time around. So we're probably looking at a much more favorable situation than many other countries, where they're finding now that they were able to contain the initial wave fairly successfully, and now they're finding large number of cases occurring all of a sudden. And it's all got to do with the number of people that have been infected in a single round of circulation of the virus, and how that actually sort of induces what is possibly community immunity or herd immunity, as we were discussing earlier. That type of initial high rate of infection paradoxically actually assists you in the future in terms of the subsequent outbreaks that you're likely to experience being less severe. Well, the answer is probably not. So we had a past pandemic in 2009, which was the swine flu H1N1. And we obviously didn't learn much lessons from that one, because 11 years later, when we had Covid-19, we weren't any better prepared than we were in 2009. The only difference was that the 2009 swine flu pandemic was much less severe than Covid-19. So unfortunately, one of the challenges that we face, and this is a global problem in many countries, is that governments only start paying attention to a problem when the problem is upon them, rather than planning for it ahead. And that is an important lesson that we need to take away from this particular pandemic, that the pandemic is always on the horizon. And it might appear to be a waste of money to be investing in healthcare systems and healthcare. But if you leave it too late, you end up spending a huge sum of money to try to redress your shortcomings from an investment that should have been done earlier, which could have been more long-lasting in terms of its benefit. So are we prepared for another outbreak? The answer is no. Or another pandemic? The answer is no. But hopefully lessons have been learned this time around that will be taken to heart, and there will be much greater investment in terms of healthcare systems in the country. Yeah, so very much so, unfortunately. So in South Africa, I think when looking at especially places such as the Western Cape and Gauteng, in terms of the percentage of people that have died, roughly about 6 to 8% of them are Muslim, which is way above the Muslim population of South Africa, which I think is closer to 1 to 2% or 2%. So it's almost 4 times higher than what it should be in the Muslim population. And it's difficult to speculate exactly what the reasons are. But I think one of the important drivers, including in the United Kingdom, where they sort of see a similar sort of disproportionate amount of severe disease as well as COVID deaths in people from the South Asian descent, is that the Muslim population and the so-called people of Indian descent in South Africa they usually have much more by way of comorbidities, hypertension, diabetes, including obesity. And much of it is unfortunately related to lifestyle issues. So those sort of underlying medical conditions, the comorbidities, increases your susceptibility to developing more severe disease. And that is possibly one of the explanations. Another explanation is, I think we did see it, at least in Gauteng, is that people unfortunately at times didn't take it seriously when they were told not to visit families. And you had this extended family gatherings around Eid, especially the previous Eid after Ramzan. And that led to an acceleration of cases in the Muslim community. And it's this belief that we're sort of immune and that we're not part of the country, which leads us to become complacent, and it comes back to haunt us. So I think people now are taking COVID-19 much more seriously because many families have been affected now, either by people being hospitalized in the family, and many Muslims have died, as you mentioned. So now it's something that's really hitting back home, but it's probably a combination of factors in terms of complacency, in terms of not adequately adhering to recommendations, but unfortunately also because of issues related to the high prevalence of comorbidities such as hypertension, diabetes, obesity. Yeah, so I think what gives me the most hope is that certainly this outbreak, or despite the large number of people that have been infected in South Africa, the number of people that ended up being hospitalized and the number of deaths from COVID-19, in fact, is less than what was predicted by the various modelers. So that is good news. And we don't exactly understand why that has happened. But one of the hypotheses is that in South Africa and many other low middle income countries, the reason why this infection might be less severe, and that's not to say that it's not a severe disease, but less severe than compared in high income countries, is that many people in these communities might also been previously been infected by what is known as the common cold coronaviruses. So there's 4 other coronaviruses that circulate everywhere in the world, including in South Africa. And previous exposure to those coronaviruses might to some extent result in an immune response, which is somehow protecting at least against severe COVID-19 illness in a fair percentage of the population. So that is good news in that the number of people that we expected would be hospitalized, the number of people that we expected would die from COVID-19 this time around in the first outbreak is much lower than what was actually predicted. So that for me is good news. And that sort of also leads to why I'm fairly optimistic that subsequent outbreaks will be less severe. Because like I mentioned, my estimate is that in communities such as in Soweto, in Alexandra, in many highly dense, in the inner city in Cape Town, as well as in KwaZulu-Natal, in Johannesburg, roughly about 40% of the population might well have been infected in many communities, which means that even when we have another outbreak, hopefully that outbreak, or even if we have a rebound in terms of number of cases, that subsequent wave will be less severe than what we've experienced this time around. And then last but not least is, like I mentioned, there's close on to 40 vaccines that have now gone into human studies. And even though out of those 40 vaccines, we'll be highly fortunate if even 10% of those vaccines work, it at least shows that we probably will have at least 4 to 5 vaccines that are shown to be safe and effective in the next few months. And then it's a challenge of deploying those vaccines, and hopefully that will assist us to get back to as close to normal as was the case in the pre-COVID era. It's not going to be about getting completely back to normal. I think we're still going to be living under challenging circumstances right through to the end of 2021 at least. Yeah, so I think the government is reporting what it knows, and people that are tested, testing positive. I don't think government is withholding any information from us. But the problem is that not everyone that should be investigated is being tested for a number of reasons. And also when it comes to people that die, unfortunately, not everyone that dies is necessarily tested, or the way that the death is recorded by the medical practitioners might not be accurate. So with regard to the number of people that have been infected, rather than being about 650,000 in South Africa, I think the true number in South Africa is more likely to be at least 7 times higher than that. So I would estimate that South Africa, there's probably closer to 4 million people that have been infected already with the virus. In terms of the number of people that have died, my estimate based on the reports from the South African Medical Research Council is that rather than there have been about 13,500 people that have died in South Africa, you probably can multiply that by a factor of 2 to 2.5. So you're probably looking at roughly about 25 to 30,000 people that have probably died from COVID-19 in South Africa. So I think those are probably where we would land eventually, at least for this outbreak of the pandemic.